Okay, hello everyone again to another video of our endocrinology playlist. That's the third video. After we already talked about the pituitary gland, the anterior and the posterior. Right now, we're gonna talk about the thyroid gland. That's an important topic. Always comes in the exams. Also, the clinic. A lot of cases comes with a thyroid issue or thyroid related diseases. Okay, so let's get started. So first of all, we're gonna talk about thyroid anatomy, and thyroid basically lays in the neck behind the thyroid cartilage. Okay, and it consists of a right and the left lobe. Both of them are connected to the median isthmus, which is a part from the thyroid itself, connecting the left and the right sides. The trachea in front of it. That's why if we have any thyroid nodules or like thyroid cancer, those nodules will kind of compress the trachea, and that compression will lead to a symptoms like shortness of breath, dysphagia, and sometimes even adenophagia. Okay, so that's why the knowing the anatomy is important. And when we talk about the physiology, the thyroid have two types of cells, have the follicular and the parafollicular. Parafollicular is not our topic today. It is the cells which is secreting the calcitonin. Our talk is about the follicular cells, okay, and they produce two types of hormones, T4 and T3. The one which is the active one are T3. T4, it's also can act in the body, but it's more like as a either as a storage form or a transporter form. Okay, but most of the actions happen as a T3, and the T4 will be converted to the T3 in the peripheral tissues. It's already mentioned here. Okay, here we can see that the hypothalamus will secrete the TRH, and TRH will go to the thyroid gland, to the pituitary gland, and the pituitary gland will synthesize the TSH, which is a thyroid stimulating hormone. It will go to the thyroid gland and makes the thyroid secrete T4 and T3. T3 will be active directly in the tissues and goes to the heart, lead to a tachycardia, which is intrope, increasing the rhythm means. Going to the liver makes it works more, synthesize more proteins and receptors, etc. And goes to the bone and leads to more to absorption of the bone, so turnover and the distractions of the bone will increase. Now move on to a important graph, and they always likes to ask this in the exams. It's about the relation between TRH and prolactin. Well, the TRH will be secreted, as we know, will be secreted from the hypothalamus, and the TRH itself, it will induce the pituitary gland to secrete the TSH, right? That's what we know. But also, in the other hand, it will induce the secretion of a prolactin, and that's why when we have a patient with a prolactinemia, first of all, we need to check the thyroid gland axis. So we're gonna order a TSH and TRH because we want to know is the case here because of thyroid issue or because of tumor secreting prolactin, as we talked about in the first presentation about the pituitary gland. Okay, super important. I can't stress enough. Always comes in the exam. Before doing anything, check medication, then check is there a hypothyroidism leading to a high TRH, which will lead to high TSH and high prolactin. Okay, move on to the disorders of the thyroid. There is a lot of classification how they classify the disorders according to if it's inflammation or not, or if it's a autoimmune or not. I don't like this way. It's more confusing. The better way that you think about it, if the disorder is causing hyperthyroidism or hypo, that's more easier and will make it solid in your brain. Okay, you will never forget diseases like this. In hyperthyroidism, I believe the most important the subclinic hyperthyroidism, because most of the part we see those cases a lot and we don't know what is the cause of it. It's just a normal TSH with a little bit high of T4 and T3. There is no anything else. A high T4 and T3 and a normal to low TSH. That's what we call the subclinical hyperthyroidism. In this case, you just follow up, okay? You don't do anything. Graves' disease, I will talk about this. That's also a common disorder. Toxic adenoma, which is an benign tumor in the gland secreting T4 and T3. We're going to talk about this one also. Multiple nodular goiter, it's the same as the first one, just a multiple adenomas. And exogenous thyroid hormone, those in people who's taking a thyroid as either a replacement or thyroid hormone as a medication trying to lose weight. So that's also an important, always check if they are taking thyroid or not. Okay, and the hypothyroidism disorders are thyroiditis, which is the inflammation of the thyroid. We're gonna talk about this one also. And previous thyroidectomy, so much common. You always when you have a picture of hypothyroidism, always ask about if the patient had any surgery before removing the thyroid, because this is maybe the only case or the only cause of the hypothyroidism, and if you didn't ask about it, you will miss this and you will do your whole workup and you won't understand what is happening, because if you didn't ask about this. Okay, central hypothyroidism means that there is a low TRH. So according to this, there is a low TSH, and low TSH lead to low T3, T4. Medication side effect, common. Comes a lot in the exams, and those medications could be like, for example, we have lithium. Okay, lithium. Also can have amylodrone, or even sometime valproic acid. Okay, that's not common, but also can be the cause here. But I will stress on lithium and amylodrone. Okay, and subclinical hypothyroidism, the same concept as the first one. Thyroid cancers also we will talk about it. Okay, so the diagnosis algorithm that goes actually for most of the thyroid diseases. So a patient came to my clinic or came to the emergency, I would say, for how can I manage this patient and know the cause of the thyroid issue? First of all, before doing any kind of imaging or ordering any lab, you need to order TSH. Okay, TSH first of all. See the TSH, because this is gonna guide you. If it's high or low, you know the picture here. Or if it's a high, then means there's a hypothyroidism. But if it's a low, then it means this is a hyperthyroidism. Of course, there are exceptions, but this in most of the cases. Okay, always check the TSH first. In those cases where patients are not taking medication, okay. But if the patient is taking medication, before even checking the TSH, remove the medication. And remove the medication which is causing the issue, not any medication, okay? Remove the medications which is affecting the thyroid. Once you remove them, then go back and check the TSH, okay? Then, according to the TSH, then you will order the T3 and T4, and those tests will give you the picture and if it's a hypothyroidism or hyperthyroidism. Okay, after you order those stuff, you'll go with ultrasound. Okay, You go with ultrasound. So if in the exam they ask you, like they bring a patient who have a problem in the thyroid, etc., and they ask you what's the next step, will be TSH, okay? And if they order the TSH, and then in this case it will be the next step ultrasound. Don't jump to T3, T4, keep it the last one. You want to do ultrasound before it, okay? All right, here, that's how the algorithm is working actually. If you have any history of thyroid issue, and then you done your physical examination, you already know that there is a let's say the patient came with a thyroid nodule, okay? Patient have thyroid nodule, and you done your physical examination and everything, you found them, well, let's say a 2 centimeter nodule. So what you're gonna order next, you will order TSH, and then the TSH, if it's high or a normal TSH, then that means that there is a picture of hypothyroidism here, because the TSH is increasing. So what I'm gonna do, I'm gonna order an ultrasound, because that's a case which is, I'm afraid of cancer in the thyroid, because most of the time cancer is cold, okay, doesn't secrete hormones. If the ultrasound show me a mass more than 1 centimeter, then I want to do biopsy here, which is fine needle aspiration, not a invasive biopsy, but just an aspiration, because I want to know if it's cancer or not. If it's smaller than 1 centimeter, then you follow up, okay? If I have a low TSH, that means that there is either a mass secreting T3 or T4, or maybe it's cold, we don't know still. So what we're gonna order thyroid scan, okay? Sometimes you find it as reactive iodine scan like this, okay? You will order this. If it's hot, that means that's adenoma. You don't do anything, you just treat the symptoms, okay? If it's cold, then this is a red flag, because that could be a cancer. So you're gonna want to do fine needle aspiration, okay? If you understand this, I think you're in great shape to how to diagnose, and I want to stress this, that's thyroid nodule, okay? Because you may do the radio iodine uptake, and it comes, let's say you have a low TSH, and then you done the iodine uptake, and it came diffuse, okay? In this case, that means that's a Graves' disease, which is we're gonna talk about, okay? Move on. That's how thyroid symptoms present in general. You should know this. You should know this. You cannot enter the exam without knowing what is the picture of thyroid hormone deficiency, and what is the picture of hyperthyroidism and hypothyroidism, okay? So in general, thyroid hormone, it's a metabolic hormone, so which is increased metabolic activity in the body. So if you have a high thyroid secretion in the body, what you have, think about it as activation of the whole body, okay? So in general, you will have weight loss, fatigue, and heat intolerance. Neuropsychiatric, we will have decreased concentration and anxiety, irritability, insomnia. Think about someone who always thinking. The cardiovascular will be activated, palpitation, tachycardia, systolic hypertension, everything is high. Also hyperreflexia, I forget it, neuropsychiatric, very important. Gastrointestinal, you have a hyperphagia, increased frequency of bowel, that's important also, because you kind of your gut motility increased. Genitourinary, you have menstrual issues, and that's the case in both of hypo and hypo. Muscle weakness also in both, and hair loss, increased sweating, and increased oil production, okay? Think about everything as an activated here. On the other hand, here, for example, weight gain, that's something unique for thyroid hormone, because if you don't have your energy unit, you cannot break down the weight, so you have weight gain. Think about it like this. The pathophysiology is complicated in this, but I'm trying to make it easy here. You have also cold intolerance, which is because you don't have your heat system, so your body cannot regulate your heat, so you have cold, which is the opposite of the hyperthyroidism. The concentration here is the same. We have, and the neural reflexes will be different. Here we have delayed relaxation, and we have constipation in the gastrointestinal, bradycardia and heart. Menstrual issue is the same muscle weakness, and you have edema all around your body. So if I want you to take out symptoms from here, always weight gain, decreased relaxation, bradycardia, and constipation. Okay, here we have weight loss, hyperreflexia, and increased frequent menstrual disturbance, and hair loss, and increased sweating. Those you can differentiate between both. We start with Graves' disease, which is hyperthyroidism. First one, hyperthyroidism, and Graves' disease, that's actually common. It's an autoimmune disease seen primarily in women, peak around age 30 to 60. Always when you have a patient with a Graves' disease, start to screen for other autoimmune disease. So let's say diabetes, let's say adrenal insufficiency, idiopathic adrenal insufficiency, or could be celiac disease. Always a screen for other diseases. Okay. The thyroid, of course, is diffusely enlarged. That's important because that's how they're gonna present to you. They said, okay, there is a picture of hyperthyroidism, and then in physical examination there's diffuse enlarged, or as I said earlier in the slides, in the rare iodine uptake, it will say it's high. It's diffusely enlarged. Okay. Brood, not always. Firm, smooth texture, don't think about this. In the examination, you have tachycardia, hyperreflexia, warm, moist skin, which is a picture of hyperthyroidism. Some patients have atypical presentation, but I won't expect this in the exam. Okay. We have Graves also ophthalmology. Graves usually have a two significant characteristics are the Graves ophthalmology, and periorbital myxedema. Those are two classic pictures of Graves. You can search about them in Google and see them. So you have edema and chemosis, which is conjunctival edema. How to diagnose Graves? First of all, as we said, we go with our algorithm. We're gonna order TSH, and TSH will be what? Will be here in this case low, and then you won't order your ultrasound. Why? Because here we have a low TSH. So what we're gonna order, radioiodine uptake, and what it will show, it will show diffuse, it will show diffuse enlargement. Okay, here we're gonna also order T3 and T4, trying to confirm, and we'll find them high. Okay, next will be our step is ordering thyroglobin antibody, and that's, we just want to confirm our diagnosis. Okay, if we have those labs with symptoms of Graves plus the thyroglobin antibody and TSI, which is thyroglobin stimulating immunoglobulin, here our diagnosis is confirmed. Okay, the treatment, well, the gold standard is doing surgery, removing the thyroid, or you would do I-131, and you will radioablate the thyroid. But in some cases, some of the patients, they don't want to do it. They just want to take medications, and most of the exam they will ask you about those medications. So remember, you give methimazole and PTO, which is a proprietary uracil. Okay. Before giving those drugs, you need always to check this. I can't stress enough. That's important here. They will always ask this. Before starting those medications, you need to check your CBC and your LFTs, because methimazole can cause hepatotoxicity and can lead also to agranulocytosis. Okay, so check those to order CBC and LFT. And In pregnancy, that's another information. In pregnancy, in the first trimester, you don't start methimazole. You start propylthiouracil in the first trimester, and then in the second you will change to methimazole. Okay, because methimazole is teratogenic as the first trimester. Okay, going to the other to the second hyperthyroidism condition is toxic adenoma and multiple nodular goiter. Both the same concept, just one is only one mass, the other one is multiple. Same concept. TSH will be low, and you will have your nodule here. You will do your scan. You'll find one adenoma, or if you do the scan, you have a multiple adenomas. If you have multiple adenomas, then that's a multiple nodal goiter. We already mentioned this. Ultrasound will show nodules. Sometimes you don't need to order ultrasound if you have already your radioiodine uptake is positive for multiple masses or one mass. So this is adenoma, and you will have your hot nodules, which is I mentioned here. The treatment, you will most of the time, if it's an adenoma, you may do a lobectomy. You remove only one lobe, and then you check if it's adenoma, then you keep the other lobe. And if it's cancer, then you will do a total thyroidectomy. You remove the whole thyroid. But some patients, they don't want this. They just want to control their symptoms, so you just do medications, beta blocker, and the same medications, which is methimazole and PTU. Okay. Also, radioiodine uptake therapy could be good, but the definitive treatment is lobectomy surgery. Okay, right now we finished the hyperfunction diseases or disorders. Right now we're going to talk about thyroiditis. And thyroiditis in a nutshell means an inflammation, because we have itis in the end of it. It's the inflammation of thyroid gland. Typically have the three phases. It starts with hyperthyroid, then hypo, then return to the euthyroid. Okay. Which one is more longer? The hypothyroid phase is longer. That's why we always put this in the category of hypofunction, because we are not expecting the thyrotoxic stage to be long enough, so we include this category in the hypothyroid. But you may run thyroiditis with thyrotoxicosis, so take care of. Etiologies could be Hashimoto, which is the most common one. We will talk about this one. Postpartum, seeing after a pregnancy, after the delivery, 2 weeks after the delivery. Okay, we're gonna talk about this one also. Medication induced, already mentioned the medication, lithium imidazole. We have subacute thyroiditis, but this is what's just seen after a infection. We're gonna talk about this one also, and specifically viral infection. Other infections is suppurative and radiation. Moving on, this is how I like to diagnose, or how I like to approach a thyroiditis. I either differentiate it into painless and painful, okay? And that's how you should do it, because otherwise you cannot diagnose it. Okay? If it's a painless, then I think about two conditions. I think about Hashimoto, and I think about postpartum, okay? And also the medication thyroiditis, okay? First one, Hashimoto, is the most common one. It's chronic lymphocytic. So if you ask you about this in step 1, they may ask you if it's a lymphocytic or neutrophils or eosinophil, etc. It's lymphocytic. Check for other autoimmune disorders, as we done with Graves. Diagnosis: diffuse painless goiter. And that's the important one. You will have a positive TPO. So how the picture here represents, the picture will be like this. You will have a high TSH, okay, and then you will have a low T3 and low T4 also. And in the thyroid, you will have diffuse painless goiter, okay. And then you will check TPO, which is a thyroperoxidase antibodies. If it's positive, then you nail down the diagnosis of Hashimoto. And the treatment is super easy. Give T4, okay? Postpartum thyroiditis is the same concept as Hashimoto. The only difference that this is after a delivery. So in questions, they present the case that after 2 weeks of delivery, the patient started having a picture of hypothyroidism, painless thyroid. Then think about a postpartum thyroiditis, okay? And medication side effect, also same symptoms, same everything. Just check your history and check if there is any medication which is mentioned leading to thyroid issues. Here we can see imidrone, lithium, interferon, alpha, and interleukin 2. I won't expect you to know all of these medications for exams. They don't ask this a lot. The only thing to focus on it is imidrone and the lithium, okay? Painful thyroiditis, it's 3 conditions: subacute and infectious, radiation. The important one is the subacute thyroiditis, which is the other name is dequervin. This is a classic question in UCMLE and also in PLAB exams. They will say that the patient had a 2 weeks of upper respiratory viral infection, and then suddenly they have a painful mass in the neck, okay, or painful thyroid. And then you will check, you will have you'll have a high TSH, low T3, T4. Then you're nailed on the diagnosis, which is subacute thyroiditis, okay? And it's associated with high ESR. And that's will guide you in your diagnosis. Important, okay? Infectious, not common, but if a patient has an infection, then suddenly developed symptoms of looks like subacute thyroiditis. If it's a bacterial infection, think about suppurative, okay? I've never seen any question with this condition. It's not common. If you already know it's subacute thyroiditis, then you are good. Radiation makes sense. If you have a patient who had history of radiation of the neck, then think about this condition, okay? Yeah, I manage the symptoms with beta blocker and steroid in case of subacute thyroiditis. Other conditions, we have a euthyroid sac syndrome and thyroid storm and myxedema coma. Euthyroid sac syndrome, actually, that's a condition in a patient who are hospitalized and critically ill. So whenever you think about euthyroid sac syndrome and you lost all the information you know about it, you feel confused, think about it. It's from its name. It's sac syndrome. Then patient have been sick for a long time and entered to the ICU, and the patient will have this condition, okay? How it looks in the labs, the TSH will be elevated or a little bit normal, and you will have a normal T4, but what's interesting here that the reverse T3 will be high. So this is how it presents, okay? The treatment, you just treat the patient in the ICU, stable their condition, and the thyroid will get back normal. You don't give thyroid hormone, okay? Thyroid storm, this is seen especially if the patient had a let's say Graves' disease or toxic adenoma, and the patient didn't get treated, and they done a surgery on the patient, or the patient had a labor, for example, any stress condition without a treatment of the thyroid condition will lead to thyroid storm, okay? It's rare. Why? Because most of the time we manage this patient before we do our stuffs. So for example, before we do surgery, we already manage the thyroid hormone. We give medications to stabilize the thyroid, then we do thyroid surgery. Before the patient got to a stage of labor, we manage the patient, okay? Myxedema coma is the opposite of thyroid storm. It means a severe deficiency of the thyroid hormone, seeing in patients which is they're not taking their medication for a long time, or as a congenital anomaly in babies who were born with the thyroid issues and they didn't get treated. In this condition, you will start T3, not T4, because you want something more stronger, works faster, and then after the patient situation gets stabilized, you will change to T4. Okay. Thyroid cancers. We have 4 types, which is papillary thyroid cancer, follicular, medullary, and anaplastic. Which one is the commonest one? Is the papillary thyroid cancer. I will talk about each one of them with its own specific character and the risk factors and the treatment. Okay. Papillary thyroid cancer is the most common one. It's seen as 80-85% or malignancy. The characteristics, this is important for step 1 cases or basic exams like pathology, not important in clinic, but what you will see is something called orphan ani. It's a characteristic under the microscope, and this is important. It spreads to the lymphatic tissue, but also can go to the blood, but it most common it go by the lymphatic tissue. Okay, you diagnose is by biopsy, and the prognosis is good actually if it's in the early stages. The treatment, we treat this by iodation, ablation, which is you do iodine ablation. Thyroidectomy is the standard, but also radiation can treat this condition. Okay. Well, the risk factor here, and that's an interesting point here. The risk factor of this cancer is radiation exposure, and also the treatment is the same. The treatment is radiation based treatment. Okay. The second one is the follicular. This one is worse comparing to the papillary thyroid cancer. It's more common in iodine deficient. How to differentiate if it's adenoma or carcinoma? You need to do a biopsy, and if you see a invasion of the capsule of the thyroid cells, then this is thyroid cancer. Okay. The treatment is the same concept here. In the anaplastic, and this is the worst prognosis of all the thyroid cancers. It's from its name. It's anaplastic, means it's not differentiated to any type of cells. Chemotherapy can help here, but it's not effective in this condition. Unfortunately, their survival rate is for 6 months at least. Thyroid lymphoma. That's a part of Hashimoto disease. If the Hashimoto didn't get treated, it will turn it to something called MALT. It will turn to a cancer, and once you treat the lymphoma, it will disappear by itself and it will be cured. Okay. Medullary. This is what I call the genetic cancer. I always like to associate it with the genetic, because mostly it's because of genetic diseases, and most common one are MEN syndrome. Okay, MEN 2A and 2B. I worked here. This is important, guys. Always, if you wanna follow up this cancer, you'll follow up by using calcitonin. Okay, because this tumor is coming from the parafollicular cells, which is the other cells, not the follicular cells, and those cells are secreting calcitonin. Okay. Patient also should be tested for RET. That's for step 3. If they ask you what's the follow-up, you're gonna ask for RET testing. Okay, and the primary is surgery, because you don't have any radiation. Radiation is only for follicular and papillary thyroid cancer. And here also you need to know this, that's a high yield. If you have a MEN 2A, okay, MEN 2 you will have um, the two P's and one M, which is you have the parathyroid adenoma and the medullary thyroid cancer, also pheochromocytoma. So before doing surgery and removing the thyroid cancer, you need to give alpha blocker, then beta blocker to manage the pheochromocytoma, and then you do the surgery. Don't do surgery in patients who have pheochromocytoma without managing it. Why? Because that will enter to state looks like thyroid toxicosis, but is worsening of the adrenal gland. The catecholamines will be secreted in the whole body and will lead to a hypertensive crisis. Okay, that's the end of my talk. Thank you all for watching. I hope you learned something from the video. Don't forget to subscribe.